Well, good morning, everyone. I am just so pleased to welcome everyone to the 2023 UW Health and Health Equity Research Lecture and Symposium. If you don't know me, my name is Ellen Hartenbach, and I'm the chair of obstetrics and gynecology. And we are so excited about this program, as we are each year. Thank you so much for joining both in person and many people online for a really busy morning of presentations and posters about research that addresses persistent gender, racial, and other health disparities. For those of you in the room, at the end of your aisle, you'll see a QR code, and it's in each row. You can scan the code to see this morning's schedule. So if you haven't done that, find your way to the QR code. It'll give you information about the posters, more information about the speakers today. And for the Zoom viewers, you can find a link to this in the Zoom chat. We have a really impressive agenda this morning, including an incredibly distinguished keynote speaker and presentations on a wide variety of health disparities in obstetrics and gynecology. This event, if you don't know the history, was started in 2005 by Dr. Gloria Sarto and Dr. Gloria Johnson-Powell. I don't think Gloria Sarto's in the room, but I'm hoping she's online. We are forever indebted to her. And it was started with the need to research and address health disparities. And the need is even stronger today. This was almost 20 years ago that these pioneering women put this conference together. And I don't think I have to tell this audience how much we need it today. I'm really grateful to the Symposium Planning Committee and our incredible events coordinator, Autumn Hayes. The planning committee was led by Dr. Sempene and Dr. Sarto. And I know I was at many of the meetings in the initial stages that started over a year ago. So this is a lot of work to put this on, and we are just absolutely grateful to that group. So we're going to start the morning with brief and brilliant talks. This was a new addition to the symposium last year, really well received. Anastasia Dougherty is going to introduce the brief and brilliant talks. Anastasia is a full scope certified nurse midwife. She's practiced for over 20 years, and she's now a member of our academic specialists in OBGYN and is part of the nurse midwifery team. She sees patients at 5 different clinics across town and attends births at Unity Merritt Point Hospital, or Unity Point Merritt Hospital. How could I forget that? So Anastasia, if you could kick us off with the brief and brilliant. Thank you so much.
Good morning. As Dr. Hartenbach said, I'm Anastasia Dougherty. And as part of the planning committee for this symposium, I had the pleasure to get a sneak peek at the brief and brilliant talks you'll hear today. Of all the submissions, these are the 5 that were chosen to best represent the focus of women's health and health equity, as well as being the most intriguing to us. You will all be voting at the conclusion of the talk, so please keep that in mind while you listen. You want to think about which presentation makes you really want to hear more. They're all going to make you want to hear more, but which one makes you most want to hear more? Because you're going to be voting right after they finish up. As you can see on the slide, they only have 3 minutes to kind of state their case that this is an important topic that we all should be interested in. The first of our talks is by Dr. Christina Warner. She is a fellow in the UW OB-GYN department with a specialty in women's pelvic medicine and reconstructive surgery. Next, we have Annalise Pantofer. She is a medical student in the School of Medicine and Public Health, slated to graduate the end of this year, and she previously has a bachelor's from UW-Madison in biology and Spanish. Then Lindsay Christensen, also a UW SMPH medical student, slated to finish in 2026. And she is coming to medical school with a bachelor's in psychology, global health, and gender and women's studies. Next, we have our Dr. Maggie Williams. She is a third-year resident in the UW OB-GYN program, and she graduated summa cum laude from University of Alabama School of Medicine before coming here. And finally, we have Dr. Jenna Nobles, who is a faculty fellow and professor in sociology at our School of UW-Madison, as well as the director of the Center for Demography and Ecology. So I really hope you enjoy these talks, and we'll get started right now.
Good morning, everyone. Thank you so much for this opportunity to present our work to you this morning. Risk Factors for Postpartum Urinary Retention, a Case Control Study. I'm Dr. Christina Warner, a third-year urogynecology fellow. In recent years, the study of postpartum urinary retention has taught us a few things. So the first being that urinary retention in the postpartum period is rare. So there are incidence estimates ranging from 1.7% to 17.9%. That it is usually a temporary condition, but when it is not temporary, it's highly morbid. And so it can result in bladder distension injury, long-term voiding dysfunction, and bladder rupture. And additionally, we know that there are factors associated with postpartum urinary retention, including prolonged second stage of labor, assisted vaginal delivery, perineal lacerations or episiotomy, higher birth weight, use of systemic narcotics, use of epidural anesthesia, cesarean delivery, and nulliparity. And although we know all of these things, there is limited research existing to inform our strategies to inform early recognition and timely management. So we sought to describe the prevalence of and risk factors associated with postpartum urinary retention, which I will refer to as PUR or PUR, at Unity Point Meriter Hospital. We performed a single center case control study where we included patients who experienced postpartum urinary retention between the years of 2019 to 2022. And postpartum urinary retention was defined as avoided volume less than 150 milliliters 4 to 6 hours postpartum and a post-void residual greater than 400 milliliters, an inability to void spontaneously within 4 to 6 hours postpartum, and then any post-void residual greater than 400 milliliters. Patients with prior genitourinary pathology were excluded, as were patients with indwelling catheter insertion for reasons other than postpartum urinary retention. Our matching parameters for cases and controls were based on gestational age, mode of delivery, and delivery date, and we matched a 1-to-2 ratio. And so our results showed that during our study period, 16,152 deliveries took place that met our inclusion criteria. Of those, 118 cases were identified. The mean maternal age for our cases was 31 years, and the mean maternal BMI was 30 kilograms per meter square. Over our study period, we noted that there was an increase in the incidence of postpartum urinary retention, nearly fourfold. This is our first table detailing some of the maternal and neonatal characteristics for our cases and our controls. Cases and controls were similar in age, race, ethnicity, neonatal birth weight, and head circumference. Cases were more likely to be nulliparous and have a lower BMI. When we looked at delivery characteristics, we found that cases and controls were similar in the intrapartum use of narcotic analgesia, spinal anesthesia, episiotomy, and occurrence of labial and periurethral lacerations. However, cases had a longer second stage of labor, were more likely to have had labor induction or augmentation, and were more likely to receive an epidural. And then looking to the postpartum characteristics and postpartum bladder management, we found that cases used more total postpartum narcotic analgesia and had a longer total length of stay. Cases also had a longer time to first postpartum void and a lower volume of first postpartum void. And so in a multivariate logistic regression, controlling for all potential confounders, we found that postpartum urinary retention remained significantly associated with nulliparity and operative vaginal delivery. And so in conclusion, we found in our study that postpartum urinary retention is rare, affecting less than 1% of patients, which has been previously described in the literature, and that nulliparity and operative vaginal delivery are significantly associated with postpartum urinary retention. And so these should be strongly considered when seeking to optimize the early recognition and management of patients with postpartum urinary retention. Thank you.
All right. Good morning. My name is Annalise Pantoffer. I'm a fourth-year medical student in Dr. Tiffany Green's Inequality Lab, and I'm a future OB-GYN. I'd like to start my talk today with a patient presentation. This is a 34-year-old Black first-time mom who's coming into OB triage at 26 weeks for evaluation of abdominal pain and right flank pain. On history, the patient reports that she started with this lower abdominal pain last night and then had some pain with peeing and increased frequency with peeing. Today, she was at work and she suddenly developed stabbing pain in her right flank and decided to come into us. Otherwise, her pregnancy has been uncomplicated. On physical exam, the patient's tearful and she's shivering and she nearly jumps off the table when I tap on her flank. At this point, I'm concerned that she has a urinary tract infection that has ascended to one of her kidneys, called pyelonephritis. This is dangerous because it can quickly turn to sepsis, which can quickly progress to death. And one of the ways I can evaluate for how close somebody is to sepsis is by looking at their vital signs for low blood pressure and high heart rate. When I look in her chart, however, I can't find them anywhere. So I go to the nurse's station and I ask, hey, did you grab those vitals? And she responds, I haven't gotten them. Her pain, in air quotes, is all over the place. The patient had been waiting for 30 minutes at that point and later went on to develop both low blood pressure and high heart rate and required admission. I share this with you because Black birthing people are 3 times more likely to die during childbirth and 2 times more likely to suffer severe life-threatening morbidity compared to white birthing people. And I share this with you because it's not an isolated incident and it is not isolated to nurses. We know that Black birthing people are less likely to be screened for pain postpartum, less likely to receive pain medications postpartum, and less likely to have their care appropriately escalated when they're bleeding out. How did we get here? Well, our attitudes and stereotypes that we hold that guide our clinical decision-making are the direct result of the systems that raise us. So, for example, up until 2021, the American College of Obstetricians and Gynecologists had a different cutoff for Black individuals that required them to be sicker before they were able to be candidates for treatment for anemia. Similarly, this is an excerpt from a nursing textbook, which my friend who graduated in 2019 had in her textbook that shows that Black people often report higher pain intensity than other cultures. If we were to look at this from a quality improvement perspective, the problem is clear. We're failing Black pregnant people. And while it's important to explore these disparities, it's also really important that we look upstream to the systems and environments that continue to perpetuate them. Until we're able to untangle our deeply ingrained biases and challenge these antiquated guidelines and constantly reevaluate the implications for our procedures and protocols, we will not move forward with this. And so I encourage us all to move forward with this lens in mind while we're approaching questions about disparities in Black maternal health care. Thank you very much.
Good morning, everyone. My name is Lindsay Christensen. I am a second-year medical student here at UW-SMPH, and today I will be telling you all about our project exploring applicant decision-making for OB/GYN residency applicants. The June 2022 Dobbs Supreme Court decision overturned federal protections for abortion. We evaluated how new abortion legislation and restrictions are impacting the real-time decision-making for applicants applying into OB/GYN residency. In order to understand one aspect of this question, we use the popular social media site Reddit. For years, medical students have posted their experiences applying to residencies and interviewing to Google spreadsheets on Reddit. On the Google spreadsheet for OB/GYN residency applicants, we analyzed a Dobbs-specific tab and other relevant tabs to answer our research question. How is the Dobbs ruling impacting decision-making for OB/GYN residency applicants? Our team of 3 researchers inductively analyzed 2,445 posts and discovered 4 themes, which I will present here. The first theme surrounded transparency and clarity, with many posters expressing difficulty knowing what abortion training was offered at each program. For one example, an applicant commented that the program director was not comfortable discussing abortion on their interview day. This lack of clarity means that applicants must use informal sources such as interview day meet and greets and social media sites such as Reddit to get these answers. The second theme was that Dobbs led to increased uncertainty in an already heterogeneous training landscape around abortion training. Individuals often commented about the fluctuating guidelines following Dobbs, expressing frustration with unpredictable changes and lack of guaranteed training due to, quote, gray areas of abortion laws. The third theme was that availability of abortion training impacts residency decision-making. Many applicants indicated family planning is a top priority in their residency selection and would be dissuaded from ranking schools higher or programs higher, if they were informed the abortion training would be limited there. The fourth and final theme was that applicants appreciate program support for abortion training. Even when programs had limited abortion training offerings due to restrictive state abortion laws, applicants still favored them or viewed them favorably if the program directors and the faculty were willing to advocate for abortion training at their site or partner sites. Overall, our results lend support to an increasing evidence base that the Dobbs decision is impacting how OB/GYN residency applicants make their residency decisions, and that applicants desire clear and accurate training information. Moreover, the limited training access for OB/GYN residents will undoubtedly impact patients' access for abortion services in an already restricted reproductive healthcare environment. Thank you.
Good morning. My name is Jenna Nobles. I'm a demographer and professor in the sociology department and a director for the Center for Demography and Ecology here at Wisconsin. I am part of the Collaborative for Reproductive Equity, and my research within CORE I have 3 points from my research in CORE that I'd like to share. The first is that health policy reducing access to abortion has spillover effects. That is, it reduces healthcare quality for people seeking for many types of patients, including and not limited to those seeking abortion. Secondly, that this health policy is unequal in impact, including inequalities by groups of people in the US that are in federally protected classes by age, race, disability, and even wealth. In some sense, these insights may be incredibly obvious to you. So the third takeaway from this is that documenting the scope of impact of these kinds of health policy changes is not only necessary, but it's possible. And it's particularly possible when we combine research and clinical insights from obstetrics and gynecology with tools from social sciences. And I'll show you one example of that here. In the case of mifepristone, which, as you know, is a synthetic steroid that blocks progesterone and in combination with misoprostol supports expulsion of pregnancy tissue. A ruling in April of this year by a federal judge in Texas initiated a nationwide ban on the provision of mifepristone. And though the appeals of this case are still ongoing and may involve the Supreme Court this fall, this is only one of many types of restrictions on the ability of the public to access mifepristone. So in states where abortion is criminalized, and particularly in states in which reporting on abortion is incentivized, patients have expressed a reduced ability to access mifepristone because providers are more nervous about prescribing it, pharmacies are more nervous about filling it, and insurers are more nervous about paying for it. Okay, so in addition to the large impact on the number of people who seek abortion, the restriction on mifepristone also has implications for other people as well. It is one of the most commonly supported form of medical support for people seeking medical miscarriage or medical management of pregnancy loss. In the first trimester, this is the safest, fastest, and most effective way to achieve complete expulsion of pregnancy tissue. For second trimester pregnancy loss, use of mifepristone prior to labor induction significantly reduces complications, including surgical management. And so the takeaway is that patients miscarrying have better outcomes, shorter process when mifepristone is part of their care. So we ask, how many people in the US experience a pregnancy loss during the period of gestation in which mifepristone is an effective and safe option for management? And we answer this by combining gestation week survival rates from both clinical and non-clinical data with counts of live births in each state, paying particular attention to miscarriages that are happening during this period of gestation in states where mifepristone is already harder to access. We conclude that each year, over 800,000 people in the US lose a pregnancy during a period in gestation in which mifepristone is a safe and effective option. This is 1/4 the size of the number of people giving birth in the US each year. Over 250,000 miscarriages are happening in states with current abortion bans, and this includes the poorest regions of the country, places that are already worse indicators of maternal and infant morbidity and mortality. We conclude then that policy restricting mifepristone access reduces healthcare quality for hundreds of thousands of people each year in areas in which reproductive health outcomes are already compromised. Answering a question like this is only possible through the combination of collaboration between OBGYN and the social sciences. And for that, I want to thank CORE for bringing this group of people together. And of course, NICHD. Thanks.
So, wow, that was a lot to consider and really be inspired to get involved, I hope, in following these people's research. I want to remind you to vote. It will be difficult, but we want the in-person attendees to scan the code that's on the end of your aisle in order to vote. Online people, there's a link in the Zoom chat box, and then you can vote and also kind of mingle in the lobby where we have posters up where you will also be voting on poster presentations. So please take some time to spend some time in the lobby, taking a look at those. And Dr. Howard's keynote presentation will start promptly at 8 o'clock. So please be back in your seats and ready to listen. Thank you.
I'm trying to learn to not ignore the online audience in our hybrid events. We're doing a better job as time goes on with hybrid events, but it's a challenge, but it's the future. It's the present and the future. So we've got a great group online. We've got a great group in the house. Really appreciate everybody coming back from the break. So much conversation, such brilliant talks. I mean, we had 5 really outstanding speakers, medical students, residents, fellows, really distinguished faculty. Like, wow, all I can say is wow. So just a couple housekeeping things. The keynote presentation this morning is eligible for CME credit. You can text that code QAQLOQ. I like that, 3 Qs. QAQLOQ. And that's to 608-260-7097. The other thing is there are parking passes in the back corner over there. Wave your arms, Carol. They're over by Carol. So parking passes to get you out of the ramp without any expense. Oh, and we have some printed copies of our year in review. So if anybody wants to really just have a one-stop shop for where, you can see some of the amazing things going on in the department. Take a copy of that. We'd be happy to share. Okay, so it's an honor to host the first ever Laurel W. Rice visiting professor as the keynote for today's symposium. In early 2022, the department established a permanent endowment in honor of our former chair, the Laurel W. Rice MD Fund in Women's Health. This philanthropic fund supports some of Dr. Rice's key passions: education, advocacy, and justice, through a visiting professorship as well as a fellowship award in mentorship and education. This endowment and the many gifts given in Dr. Rice's honor to the fund are just one way she continues to have an immeasurable impact on our work. So the Laurel W. Rice Visiting Professorship brings scholars here to Madison to present on research and innovation across women's health. I'm just thrilled to introduce Denise Howard as our inaugural Laurel W. Rice Visiting Professor. Before we do that, we have to acknowledge that Laurel Rice is in the house, everybody. So, this morning's not, all about Laurel Rice, but we all stand on her shoulders. I personally stand on her shoulders. And so it is just fabulous to have you here, to see you in person, and to welcome you to this event. Okay, now moving on to Dr. Howard. She's an amazing person. We are so delighted she's here. She grew up in Columbus, Mississippi. She did her undergraduate work at the University of Mississippi and then attended Johns Hopkins, receiving an MD, MPH in 1993. She completed a residency in obstetrics and gynecology at the University of Pittsburgh McGee Women's Hospital in 1997. We have some McGee graduates here as well. Then she did a fellowship in urogynecology at the University of Michigan, where she then stayed on faculty for many years. She was there until 2001. And at that time, she relocated to the Atlanta area, where she was in private practice until 2010. She and her family moved to the Middle East, where she worked in various leadership positions in Abu Dhabi, in the United Arab Emirates, and in Doha, in Qatar, before returning to the US at the end of 2019. So she's already been around the world and lots of places. And now, in the most recent years, she has served as the chief of gynecology for the Geisinger Health System in Danville, Pennsylvania, where she also had a faculty appointment at the medical school and served as core faculty for the residency program. She specializes in gynecologic surgery and women's reproductive health and is currently an assistant professor of clinical OBGYN and vice chair in the Department of Obstetrics and Gynecology at Weill Cornell Medicine, as well as the site chief at the New York Presbyterian Brooklyn Methodist Hospital. So she was telling me the New York Press hospital system is a 10-hospital system with connections to both Cornell and Columbia. And it's an impressive and large organization. And she's the site chief at New York Press in Brooklyn. She's a board certified obstetrician gynecologist, a fellow of the American College of Obstetrics and Gynecology, and a certified physician executive. She's also a member of the Society of Gynecologic Surgeons and the American Association for Physician Leadership. Dr. Howard is committed to ensuring every single woman receives quality care. She believes improving health literacy, engaging women, and incorporating technology into healthcare delivery is the way to equitable health. Welcome, Dr. Howard. We are so delighted you're here.
Thank you for that warm welcome. I'm honored to be here and to have been invited to give this inaugural professorship for Dr. Rice, who I met last night and had a lovely dinner with, along with Katie and John and Christina. I was about to say, thank you. So we've done some amazing things in medicine. I think about the germ theory of disease, vaccinations, anesthesia, minimally invasive surgery, robotic surgery, HIV therapy, hormonal contraception, 3D printing, and so much more. So knowing that, I know that we are up to the task of taking on our greatest challenge. And today, I think that is eliminating healthcare disparities. So I don't have any relevant disclosures. My objectives for this talk, I want to use some patient stories to illustrate some of the things that I think contribute to health inequity. I'd like to summarize some disparity data in OBGYN, and I know many of you know some of this, but I would like to highlight it. Recommend some areas of focus if you sort of take on the challenge that I have for you. Give some examples of some solutions that different institutions have taken on. And finally, I hope to inspire you all to act in some way. So you gave a nice summary of all the places that I've been to. And I put this up here to indicate that I have been in academic settings and private settings and government settings, in rural and urban settings, and in international settings. So I've seen the inside of a lot of healthcare facilities. In addition, I've taken care of a diverse group of women, all along the entire economic spectrum, different nationalities, races, ethnicities, and religions. So contextually, some of the things that I'm talking about is from personal experience. So I know a lot of you also can relate to this statement, because I felt like there was a point when I was in the Middle East that I actually surfaced from what I describe as an all-encompassing task of finishing your medical training, mastering your craft, motherhood, being a wife, and then the shedding of the financial debt that many of us take on when we go into this field. And I finally started to pay attention to some of the things that were going on in the world, especially in the United States from afar. And what I saw was pretty disturbing. And it brought to me the duality of healthcare in America. We have the best and we have the worst. So I'm going to tell a few patient stories. And I say patients, a few women's stories, because they weren't my patients. What I know about these stories are what I've read in the press. I don't have any insider knowledge, but a couple of the accounts came from the husbands. I don't know if you know who this young lady was. Her name was Kira Johnson. She was 39 years old. She went in for an elective repeat C-section to a major medical center in Los Angeles. In the recovery room, she started having pain and complaining. The pain got worse. She was writhing. She became pale. She was sensitive to the touch. The husband and family asked for help, asked for some evaluation. I don't know at what point blood was in her Foley catheter, but there was blood in her Foley catheter. A CT scan was ordered, but never done. After 10 hours, they took her back to the operating room to find a lacerated bladder and 3 liters of blood in her in her abdomen, and she died on the operating table. So when I think about her, I ask myself, what the heck happened? Was there a deficit in expertise in this situation, or was it just plain negligence? This is another highly accomplished young lady. She was a lieutenant commander in the United States Public Health Service, an epidemiologist at the CDC. At 36, she had a vaginal delivery. 3 weeks later, she was not feeling well at all. Went to see her provider. A few hours later, she collapsed at home, had a cardiac arrest, and died. Cause of death, hypertensive complications of pregnancy, is what I understood from reading it. When I think about her, I ask, is there a lack of heightened awareness to the things that we know happens in the peripartum period? Is there a lack of vigilance? If she's telling you that she's not feeling well, she gets sent home and she dies a few hours later. This one was a long story that I read, and this was the husband's account. And the title of this article was The Last Person You Expect to Die in Childbirth. Her death happened in 2011 in New Jersey. This was written in 2017. On the surface, you think that we say this because she's a non-Black person, but more about her story. Lauren Bloomstein, she was a NICU nurse. Her husband was an orthopedic surgeon, I assume, still. She handpicked her obstetrician. She chose to deliver at a hospital where she worked, knowing that her friends and colleagues would look out for her. After her delivery, she started to have symptoms as well. And the report says that her blood pressures had been elevated from the time of admission, but were not monitored consistently. She developed abdominal pain, nausea and vomiting. She was evaluated. The husband, I think, was so distraught, he called a friend who was a trauma surgeon outside of that hospital. And the trauma surgeon said, sounds like she has HELP syndrome. When he, I guess, communicates this to the healthcare team, they say, well, the labs don't show that. Her pain continued. She was given morphine, evaluated by a surgery resident. At about midnight, her blood pressure spiked to 197 over 117, and she developed stroke symptoms. Well, then now at this point, her labs do show HELP syndrome, and her platelets are low. The neurosurgeon can't take her to the operating room because platelets are not immediately available, so he has to wait for platelets, and she dies. So clearly, she was in a place where she was highly valued. So our quality processes must be ineffective, or the quality processes here must have been ineffective. I think we all know her. She's alive and well, Serena Williams. Serena had a pulmonary embolus in 2011, long before she was pregnant. So she was very aware of her condition. Shortly after her C-section with her first child in 2017, she developed symptoms that she knew was a pulmonary embolus. Not wanting to disturb her mother, she got out of her bed. She was attached to an IV pole. She left her room, went down the hall to the nurse's station and said, I need a CT scan and I need heparin. I'm having a pulmonary embolus. She was initially brushed off, but thankfully she got the care that she needed. In this case, this is an example of things that we hear a lot, is that we don't listen. Finally, the last one, a fellow Mississippian, Tori Bowie, died earlier this year. She was in Florida. If you know anything about her, she had won 3 medals, track and field, at the 2016 Rio Games. Tori died at home. She was about 8 months pregnant. They said that the cause was probably eclampsia or hypertensive complication of pregnancy. She had a history of bipolar disorder. The thing that struck me was what her agent said, that she didn't trust the healthcare system. And it sounds like there was a plan to deliver at home. So because of her lack of trust, she was not in a position to be taken care of. So we know that trust is a big issue with our patients. So when I look at these stories, there are a couple of things that strike me. First of all of these women are educated and well-resourced, and they have power. And if this is happening to them, what about all the unnamed, powerless, voiceless women out there? Things that we probably don't ever hear about. What about them? The other thing that strikes me as a Black woman from Mississippi, an OBGYN, and a healthcare leader, is that I have some degree of responsibility. And I feel like I have some responsibility. And I ask myself, well, what is my responsibility? And I hope that all of you will ask yourself the same question. What is your responsibility? I ask myself, what is within my power to do? And I think you should ask yourself, what is within your power? What do I have the expertise to do? So moving on, I want to start with some definitions. And we'll talk about health equity. And it's defined as a fair and just opportunity to attain the highest level of health. And not all of us have that opportunity. Not all of our patients have that opportunity. But in order for everyone to have that opportunity, we need to address historical and contemporary injustices that we know exist. We need to work to overcome economic, social, and other obstacles to health and healthcare. And we need to work on eliminating preventable health disparities, and there are many out there. One of my colleagues that I work closely with, she's in internal medicine, and she does a lot with community engagement, shared this slide with me because I think this is a great example of a picture being worth 1,000 words. So talking about inequality on this, finding my slide. Okay, on this one, you see this person, the tree is leaning towards her, and then there's more fruit on this left side of the tree, right? That's inequality. On the right, they're given the same tool, which is in essence equality, except the tree is still leaning to the left and there's still more fruit on the left side of the tree. When you get to equity, then you talk about giving people the tools that they need. It's not that everyone needs the same tools. Some people need a little bit more of a boost. So the person on the right now has a higher ladder and is able to reach the fruit, but there's much less fruit on her side of the tree. And finally, health justice, and justice comes in when everyone has an equal opportunity, equal access, and the fruit is distributed to the same, and the tree is no longer leaning. So quality, we've been talking about quality for decades now, and I think about when we first started talking about quality, and then recently with the elements of quality. And we can't say that we're delivering quality care until we can say that it is effective and it is efficient and it's safe and it's timely and it's patient-centered and it's equitable. That's what quality care looks like. So I want to go over some disparity data. First of all, when you think about the United States, which is a very rich country, and we compare life expectancy in the United States to a comparable country and how much we spend on our healthcare, you can see that our life expectancy is much lower than a comparable country, and we spend twice as much as that comparable country. So even for everyone, our healthcare is not delivering the value that we should be getting. Then we think about life expectancy, and our life expectancy has dropped over the years. And that's happened for all groups. First, if you start with African Americans and Native Americans, American Indians and Alaska Natives, the life expectancy is significantly lower than the other three groups, Hispanics, Asians, and whites. But for all groups, that life expectancy has declined over the years. Some a couple of years, 6 years for the Alaska Natives and American Indian. So our healthcare is not servicing its minority groups at all well, but it's not servicing all of us well. Maternal mortality, the rates have increased. We know that the rates have increased. It's a good thing that we're talking about it and we're having this discussion, but you can see from 2018 to 2021, it has increased significantly. And you can see that for Black women, it's significant, the increase, 3 times higher than their white counterparts. And that definition for maternal mortality was from the end of a pregnancy, whether it be an ectopic or a miscarriage or a termination or a delivery, up until 42 days. But if you look at the year after a delivery, you'll find that a significant amount of deaths that occur past that 42 days, 30% in this case. So when we think about taking care of women, we need to take care of them not only in the immediate postpartum, but we need to think about what's happening to them in that entire year after pregnancy. So these disparities also exist in gynecology. This looks at opportunistic salpingectomy, and we know that removing the fallopian tubes when we have an opportunity decreases the lifetime risk of ovarian cancer. Well, this study looked at the racial and ethnic differences in the adoption of opportunistic salpingectomy for the prevention of ovarian cancer, and this was from 2011 to 2018. One study of one group, almost 83,000 women, 60% of white women were able to have an opportunistic salpingectomy at the time of a hysterectomy. For Blacks, it was less than 20%. For Hispanics, it was less than 13%. For the other groups, less than 9%. Looking at a group of almost a little bit over 23,000 women who underwent an salpingectomy for sterilization or who underwent a sterilization procedure, less than 65% of white women had a complete salpingectomy for her sterilization procedure, less than 11% of Blacks, less than 17% of Hispanics, and less than 8% of others. This is a life-saving procedure that's easily done at the time of a hysterectomy, easily done at the time of a sterilization procedure, and yet the majority of our women are not getting it. And as with other data, minority women are disproportionately being affected as well. We know that aspirin prophylaxis for people at high risk can reduce the risk of preterm preeclampsia, preterm severe preeclampsia. And there's not that many studies that look at aspirin use in these groups. This is one study. They found that 65% of women were recommended, women who were at risk were recommended to have aspirin. And they say in the study that Black women were equally likely to be counseled. But you know, what does counseling mean? Hey, you should take aspirin. It'll prevent you from getting preeclampsia. See you in 2 weeks. Well, that's not sufficient counseling. That's not enough to convince anyone to take anything. Thus, the rates for Black women were a lot lower than the other groups. But overall, 65%, we know that this is effective. More than 65% of our women who are at risk should be counseled on the importance of aspirin. This is not in gynecology, but it looks at surgical experiences, because I think all of us know when we counsel people on surgery that the process is woefully inadequate. We don't have enough time and we don't do a good enough job. But in this study, the groups all thought that they needed more information. The African-American patients felt like they were given incorrect information, given no expectations of outcomes, provided inconsistent information, and some of them said they felt misled. So Weill Cornell examined their experience with referrals to the Hereditary Breast and Ovarian Cancer Center. And when they looked at the referrals for patients between 2013 and 2016, they had almost 1,400 white women referred. They had 85 Hispanic women, 101 non-Hispanic Black referred, and 113 Asian. So even referrals for this potentially life-saving care, there's significant disparity. Uterine cancer, we know that, well, we all assume, and this is what I used to think, it's one of those cancers that's easily treated because you can detect it early. It's really common, and it's the most common GYN cancer other than breast. And when you look at the incidence rates, Native Americans and Blacks have a higher incident rate, but when you look at the death rates, the rates for Black women is almost twice that of some of the other groups. And there are a number of reasons. It's complex, but Black women are twice as likely to die as a white woman with the same diagnosis and the same stage of disease. They tend to have a higher incidence of uterine cancer. They are less likely to be diagnosed at an early stage. They're less likely to get the same care. They're more likely to have a more aggressive type of cancer, non-endometrioid type, which can be more aggressive. Cervical cancer rates are higher in Native Americans. When you look at outcomes, Native Americans and Black are a little bit more likely to die from cervical cancer. And that's not because of screening. For Black women, it's because of the surveillance that happens after screening. Cervical cancer, I'd like to say cervical cancer should be a never event. And it should be a never event because we have the tools to prevent it. The Pap smear revolutionized our care for women to prevent cervical cancer. The rates dropped significantly until 2005. But there are pockets and places in the US where the rates are significantly higher. And this map shows you where those places are. And I think we all can easily conclude because the screening and probably the HPV vaccination are not utilized as well as they could be. These are the same places where people die from cervical cancer. The American Cancer Society every year gives us an estimate of the number of cervical cancer cases they think will happen and the number of deaths. And as long as I've been looking at it, it seems like we're hanging out at around close to 14,000 cervical cancer cases and 4,000 deaths. And we haven't moved the needle in a few years. We have tools, and they've been around for a long time. The Pap smear first came on the scene in the 1940s. It was the 1990s when thin prep was introduced. I remember going from the wooden spatula and putting it on the slide and spraying the stuff, the fixant on. And then, the introduction of HPV co-testing and reflex testing in 2001, really changed the game. I thought it changed the game. And then the availability of the HPV vaccine in 2006. Yet, after this point, I'm still surprised when I go to the many places that I've practiced in that sometimes HPV co-testing wasn't done and screening is completely inadequate in a lot of those places. So I guess I just explained why there's still cases, but I like to talk about how women fall through the cracks in care along this continuum of cervical cancer prevention. A lot of women don't come in for PAPs, or they come in to see a family medicine doctor or a primary care physician, or they come in for a problem, or they even come in for the OBGYN docs for a problem, but the Pap smear doesn't happen. I'm deeply embarrassed every time I hear a patient say that she was told to come back for an annual exam. I think that if a woman is there, especially if you're doing a speculum exam, the Pap smear should happen, but it doesn't always. Let's just say she has an abnormality and she's referred for colposcopy. She doesn't come in for the colposcopic evaluation, or she has a biopsy and there's an abnormality and she needs surveillance or she needs treatment and she doesn't get that appropriate treatment for a number of reasons, system reasons, challenges that she may have, but these are all of the opportunities for her to fall through the cracks in care and get cervical cancer, and that's why we still have cervical cancer cases. So with that, I think about all of that and I have questions. I ask myself questions. And hopefully you too are asking yourself, why is maternal mortality rates, why are the rates increasing? Why do we have so many dramatic stories? A woman should not die from an elective C-section because of our failure to take her back into the OR in time because she's clearly bleeding. Why do we all let this continue? We healthcare providers, healthcare systems, our politicians, and even our citizens. Why did it take a pandemic for telemedicine to take off? Why hasn't cervical cancer been eliminated? And why do we tie contraception to a healthcare visit? When I lived in Abu Dhabi and Doha, I could walk into a pharmacy, buy a pack of birth control pills, combination birth control pills, for less than $5 a pack. One of those countries is considered to be a relatively conservative Muslim country, but contraception was available in the pharmacy over the counter. So I think in saying all this, I think we all recognize that our patients, our women, are not getting the care that we think they should. Our healthcare is not what we imagine it should be. I think that our model of care delivery is not sustainable. I think the pandemic unmasked that and showed us a lot of problems that some people saw. But we need a new way forth. We're stagnant in our delivery. And as far as quality is concerned, we're stagnant because quality is not incentivized. In all our healthcare, we talk about RVUs, we talk about productivity. We've attempted to do some incentivization around quality, but it has not taken hold. We lack an ability to implement evidence-based practices on a large scale. Cervical cancer prevention is a prime example of this, especially with the HPV vaccination. We don't use our resources as efficiently as we could. We have nurses doing tasks that a medical assistant or an administrative person could be doing. We all do tasks that probably could easily be automated. And with that, we don't focus on innovative delivery methods. And I think we don't think innovatively. From a cultural perspective, thinking innovatively needs to be embedded in our culture of medicine. So then I ask myself a different set of questions to try to come to my way forward, or what I can do to make a difference, or how I can contribute in my position. So how can we consistently deliver the same level of care to every patient, independent of provider, independent of location, and independent of time? And I say time because I think if you all examine your day, you go in, you're on time, you're energetic, you're caffeinated, you're not hypoglycemic, you can think well, you interact with your patients. By the end of the day, you're exhausted, you might be hypoglycemic. That last patient may not necessarily get the same type of care that 10 o'clock patient received. How can we provide objective care? Eliminating the subjectivity and the bias in care delivery. We all have biases, right? Biases have advantages, but they have a lot of disadvantages, and they sort of dictate how we approach things. So how can we do that? Well, I think a lot of people have lots of ideas, and this guy, Chris Trimble, wrote a book because he thinks that physicians are the key to this. He thinks that physicians can change medicine one innovation at a time. He said, in the book, that the implementation of processes to minimize human errors, remove biases, and deliver consistent quality isn't easy. No, it's not. But so is the development of a 3D printing, minimally invasive gynecologic surgery, vaccinations, developing contraception. None of that's easy, but we've accomplished that in medicine. He thinks that a groundswell of physician innovators determined to rebuild care one step at a time is exactly what our healthcare system needs, and I agree with him. So an aside, you guys, I finished my residency in 1997, as you guys heard, and I remember this commercial, and I don't know how many of you guys remembered this Apple commercial, but it resonated with me, and it went something like this. Here's to the crazy ones, the misfits, the rebels, the troublemakers, the round pegs in the square holes, the ones who see things differently. They're not fond of rules. You can quote them, disagree with them, glorify or vilify them, But the one thing you can't do is ignore them because they change things. They push the human race forward. And while some may see them as the crazy ones, we see genius. Because the ones who are crazy enough to think that they can change the world are the ones who usually do. So I saw this slide, and this said, disruptive innovation and technologies will create new ways delivering effective healthcare that will overcome acute shortages of both capital and skills. And that's where we are. We have shortage of capital. Pandemic showed us that. And in lots of cases, we have a shortage of skill sets. Nursing resources was a great example during the pandemic. So a bit about innovation. I'm going to go over innovative types. There is something called incremental innovation. The mobile phone is a good example. I remember being a resident and one of the private OB physicians coming into the call, and he had this huge first mobile phone that looked like a walkie-talkie, but it was bigger than a walkie-talkie. My first phone was one of those flip phones. Then texting was sort of very challenging, but you could start texting a little bit on those flip phones. Then we got the smartphone, and then Apple invented the iPhone and has cornered the market, right? That's an incremental innovation. An architectural innovation, Amazon did it. Amazon took an existing technology and they created a new marketplace. They went from delivering goods to books to medical supplies, and now they're trying to take over the world. There are radical innovations like the airplane that invented a whole new industry around travel and product delivery. And then finally, my best favorite example is this disruptive innovation, and Netflix is a great example. You guys remember Blockbusters? And we were all so happy over on a Friday to go to the Blockbusters and pick up our, I think, initially it was like the films and then the CDs, pick up a few, but you had to get it back Monday morning at a certain time. Otherwise, there'd be those late fees, right? Yeah. Netflix came along and said, hey, you don't have to come to us. We'll mail it to you. And don't worry about those late fees. And then they started streaming. And then they started making their own movies. And now they're working on putting Hollywood out of business. Netflix is a disruptive innovator. And I think we need to disrupt healthcare delivery in OBGYN. And I think we can. So that's a big task though, right? So why should we do it? I hope that you're convinced from what I've said before, the reasons that we should do it, but the other reasons is why we went into medicine in the first place. Remember the Hippocratic Oath, and then I'm sure if you're not a physician, you've taken some type of oath. The health of my patients will be my first consideration. I will maintain by all the means of my power the honor and the noble tradition of the medical profession. Well, the noble tradition of the medical profession is to innovate, to push the science of medicine forward, to solve problems. This is another quote I like. I chose medicine because I can think of no other professional avenue more challenging, more rewarding, more evolving, and noble. Well, what's more challenging than trying to eliminate healthcare disparities? What's more noble? And when we do this, we will push medicine forward and ensure quality for everyone. To us, success means we go to sleep at night knowing our talents and abilities were used in a way that served others. Bright and brilliant people go into medicine. There are other disciplines that you can go into, but a lot of people go into medicine because they want to feel like their abilities and talents are used in a way to serve their fellow man and woman. So then the question becomes how? How can we do this? Well, we're actually doing it in certain areas. The surgical safety checklist, I think, is the best example of that. It's simple, it's innovative, it's clever, but it has eliminated wrong site surgery, has essentially eliminated wrong person surgery, and this is in every operating room in the world. My guess, I haven't been in every operating room, but it was in the operating rooms in the Middle East. I visited a couple of countries in Africa. It was in the operating room there. The WHO is pushing it. This is a simple innovation. We do risk assessments. The VTE risk assessment is an example that also is innovative. And it's a way to make sure that objective care is being delivered, consistent care is being delivered. We do it with hemorrhage bundles and other sepsis bundles in obstetrics and gynecology. So we're already doing it and we're thinking about it, but I think that we can do better. And there are places that we can do better. So when I was in public health school, this is the first time I think I was exposed to this quote, and I love this quote. An ounce of prevention is worth a pound of cure. And Benjamin Franklin said this when he was talking about fire prevention in Philadelphia in his day, but it applies to medicine. And the thing that was always so perplexing to me as a student and as a resident and even as a practicing physician, we spend a lot of time talking about the marvels of what we do for specific disease therapies. We don't spend enough talking about how we can prevent. What are the opportunities for prevention? And we have a few in OBGYN, life-saving care. And I talked about some of them earlier. A bilateral self-injectomy can reduce the lifetime risk of ovarian cancer. If we were to remove the tubes when we have a chance at a hysterectomy or at sterilization. Genetic screening and identifying people who have mutations that put them at high risk and allowing them to have risk-reducing bilateral salpingo-oophorectomies can decrease their lifetime risk by 96% of developing an ovarian cancer. Aspirin prescribed to high-risk patients reduces severe preterm preeclampsia by 62%. Enhanced recovery after surgery, when done in a comprehensive fashion from A to Z, decreases the length of stay, decreases the narcotic use, decreases complications, saves money for healthcare systems, and yet we don't implement this in a comprehensive, effective manner for everyone. And of course, vaccines and the HPV vaccine rate is less than 50%, and we know it's effective in preventing cervical cancer, and then the screening tests that we know are effective, PAPs and colonoscopies and mammograms and HPV screening. So those are some life-saving things that we all can do better with. And so I wanted to spend a little bit of time reviewing some solutions that some people have come to, and I'll breeze through some of this. But when we think about a solution, we should make sure that negligence should never happen, that we do what we can to make sure the right experts are available to address certain things like the case that I presented. We need to focus solution on increasing our vigilance and heightening our awareness. Quality processes need to be tightened up. We need to learn to listen better, and we need to come up with ways to build trust with the women that we take care of. And so when I think about a relentless focus on quality, these are things that I think about, things that I have been involved in, or things that I hope to do. We need to incentivize quality for our healthcare providers, workers, OB safety officer in the busy labor and deliveries, huddle simulations and team training has been proven to make a difference, but I think that it's not done effectively in every labor and delivery unit in the country. Our M&Ms, we have outcomes. We need to make sure that we identify and work on solutions that our M&M tells us are problems. Setting goals, tracking metrics, implementing effective protocols like the enhanced recovery after surgery. I met a woman in the New England area, and she and her colleagues developed contraceptive counseling tool, a shared decision-making tool that was focused on what the patient valued. It wasn't about what we as physicians see as important in the contraception. That's an example of things that are being done. Focus on improving the patient experience. Culturally sensitive care, trauma-informed care. I think that emotional intelligence training for providers would be very valuable, because I think it helps us to handle difficult situations with patients better. We need to focus on addressing physician burnout, because of course it is a real thing and it can contribute to issues. Now, this is something I can't take credit for because it happened before I came, but this is my hospital. And when the pandemic happened and pregnant women were separated from their partners. Our midwives came up with the idea of introducing doula services. And it was extremely popular. And we continued it after the pandemic. We have labor doulas and we have postpartum doulas, and our patients love it. And it is one of the things that makes our hospital stands out amongst other hospitals. And we have other hospitals that are trying to mirror what we're doing. Rebuilding trust. What are the things that we can do to rebuild trust in our communities? We spend a lot of time involving and engaging with the community. We have events and we have things like, I think there was a baby shower for some of our pregnant patients in one area of Brooklyn. We have nanny days when we talk to the nannies. And there's a large group of nannies in the area around our hospital about healthcare. There are a lot of community-based organizations that are doing great work. So we engage with them. We partner with them for a lot of our initiatives, even some of our upcoming research things that we're doing. And then, we look to add valuable services. So this is one that I think is pretty amazing. But Cornell has a grant from the March of Dimes, and they have a mobile medical unit. And that mobile medical unit is going to serve areas in Brooklyn and Queens, and it's designed to provide prenatal care for women who would not come to us or to any health system. And the objective is to provide this initial care and connect them with healthcare wherever they want to go. The plan is to park in places where it's accessible to women, like in front of women's shelters. So innovations to eliminate subjectivity in care, things as easy as like standardized templates, which is some things that I've done for a long time. And we've implemented some standardized templates so that as a healthcare provider, you're prompted to remember to do certain things, like a well woman exam, making sure she has her colonoscopy, her mammogram, she's current on her pap smear, she got her bone density if she's over a certain age. I think artificial intelligence or machine learning will add a lot of value to healthcare. You just need to think about in a thoughtful way how we can implement it to provide better care to our patients, communication platforms to provide patients with timely, relevant information. And then I mentioned a shared decision-making tools. Cornell did this, and the woman who led this project, they developed a web-based interactive risk assessment tool, taking the provider out of it, but allowing patients an opportunity to answer select questions to see if they are at high risk of having a mutation, offering continued counseling or even screening, and even setting them up for that screening. And that addresses the disparity in referrals for this genetic counseling. Let me skip to this. And then one of my medical school colleagues, I ran into him for a 25th medical school reunion, and he was telling me about his company. He developed this company with the chronic medical patient in mind, but then he soon found that it was actually a perfect platform for surgical. So he's used it in orthopedics and plastic surgery. But the thought behind this is that if a person is scheduled for surgery, they will receive specific instructions when it's needed. An example, you have a patient who's scheduled for an abdominal hysterectomy and she's on Coumadin, or she's on warfarin. She gets a message, I'm gonna say 2 weeks, I don't know if 2 weeks is right, 2 weeks before the surgery. Your surgery is scheduled for this date. Remember to stop your Coumadin today. Start your sub-Q heparin tonight or tomorrow morning. Maybe it's the night before. Remember to use that abdominal antibacterial wash today, right? Day after surgery, you should expect this, this, and this. These are the medications that were prescribed. Remember to take your medication. So in their preliminary work, they showed that this actually decreased the number of phone calls to the offices when they use this platform. So an example of innovation. So what am I doing? I am working actually to try to come up with a hard stop screening at Epic for risk assessment for preeclampsia. And then there are a lot of different steps that we need to do to make sure that when we think a patient needs aspirin, that we reinforce the importance of aspirin. So this is a work in progress. And the other thing that I'm trying to convince my health system to do is to work with me to use a platform like the one that I told you, not necessarily that platform, but to deliver this timely, relevant perioperative teaching. And I think that we could eliminate a lot of the phone calls that we know our nurses in the peri-op area do the night before. And that is a way to sort of start to use our resources more efficiently. Those are my ideas. But I think when we, this whole process takes a lot. And I think understanding it is one of the most important things. And a couple of recommendations, if you don't mind. Medical Apartheid is a book that I read. And I think that if you want to understand why African Americans react the way they do when you are making recommendations, I think understanding the dark history of medical experimentation and Black Americans, descendants of slaves, will help you understand how they act and react when you're trying to provide them with care. And then this book by Heather McGee, The Sum of Us, talks about what racism costs all of us. And it's not geared necessarily towards medicine, but it talks about all of the lost opportunities we have to provide quality of life services to everyone. And racism has prevented us from doing that. And so not only are minority groups affected, but all groups are affected. So a couple of understandings. So in summary, we have quality interventions, but we fail on consistent delivery. We need to rethink our model of healthcare. Innovative solutions are one approach to providing consistent, objective care to eliminate health disparities. And I want to challenge all of you to think about how you can drive disruption in OBGYN. So I'll end with questions. What will you do to ensure that everyone receives the life-saving care that's already available? What will you do to make sure that the enhanced recovery after surgery protocol is implemented in a comprehensive fashion? What will you do to decrease the maternal mortality, to make sure preventative care is provided? What will you do to make sure no one falls through the cracks of care for cervical cancer prevention? What will you do to make sure that OBGYN disrupts healthcare? So people who are crazy enough to think that they can change the world are the ones who do, based on the wonderful presentations I've heard and seen and the group of people that I've met. I know that there are a lot of crazy ones in this audience today. So thank you for your attention.
Stay right there.
Okay.
All I can say is thank you so, so much. That was, a lot of information some of us have seen, but the way it was synthesized, the way it was presented, the way it challenges us to really think through these things and how we can act as individuals, I think is super important, because there's times when we feel helpless in the healthcare system. So thank you so much for all of that. We have some time for questions. We've got, microphones. So let's get started. Who has the first question for Dr. Howard?
I'll take the first question. It's kind of maybe leading, because I'm Hannah Barton. I'm a postdoctoral research associate, and my field is human factors, which is really about how people interact with systems given our capacity as human beings. And so my question is, you talk about vigilance and the role of vigilance in reducing healthcare disparities, right? But then you also talk about burnout. Like, what do you see about that interaction, right? How do we actually, prevent disparities and address vigilance without putting more work on ourselves as clinicians when we're doing a lot?
So you're absolutely right. Burnout, we're overworked, we're asked a lot. And so one of the things I think is we need to reimagine how we deliver care. I, a long time ago, determined that 24 hours being on call for OBGYN was too much. I personally said this. There is a lot of challenges to that, but I think that the systems that have gone to 12-hour systems, that's wise. You can be better vigilant. You can be on your game when you are working 12 hours as opposed to 24. There's lots of discussions about a 4-hour work week, not just in healthcare, but in other areas. So I wonder if there's a way that we can modify and congest our hours, but of course it's going to cost. So needs to be a lot of financial reckoning. But those are the things I think. We need to reimagine our model of healthcare delivery, taking in mind that humans can only do so much, and you can't expect perfection out of someone who's overworked and inundated, overwhelmed. So.
Other questions? I'll just add a comment. I just saw a slide. We went really low in maternal morbidity and mortality. I think everybody knows that in the world. But just next to that, I saw the graph that said how many OBGYNs, certified nurse midwives, obstetrical providers do the different countries have that have better rates than we do? It's a lot more people. It's a lot more people. We need to have people who have enough time to really think through these innovations and implement them. And going from 12 to 24 to 12, that's like, why didn't we think of that sooner?
Yeah.
Dr. Howard, I just want to say thank you. That was so well organized and inspiring. And I don't have a question. I think the way you presented the information is, again, just inspiring. Thank you.
Thank you. That means a lot coming from you.
Hi, I'm on.
Yeah, I think Luther, do you have a question for Dr. Howard?
Yes. Hi, Dr. Howard. I met you yesterday at lunch, Luther Gaston. And I want to say thank you for that inspiring talk. I was just listening to it with my wife because I'm one of those folks who does think I can change the world. And slowly and one person at a time. It's just refreshing to see somebody that has that similar attitude, because what we're doing in America is not acceptable to any woman, let alone Black women and Native American women and things like that. Another question I have for you, I just read this out of UCLA, which is where my buddy goes to get his health care. And they did a research project that showed, and I do try to educate our residents on oppression. Because what they found was 2/3 of white people had no clue that Black people were discriminated against in the healthcare system. We have a country that tries to not educate other groups, whether it's Asian, Latino, Blacks, whites, anybody, on really what happened in America to put us in this predicament as African Americans in the first place. And what they found is once they educated some of the healthcare providers, their attitudes change. And that they think that may be a vehicle to help with some of this healthcare disparities and flat out discrimination, to be honest with you. And my brother, he joked the other day, he's a urologic oncologist at University of Texas, Dallas, and he said, "You all having diversity lectures up there? But they eliminated our diversity up here." Well, if you can't educate people and they want to take books away and diversity programs away, how are we going to make diversity education and/or disparities better with people that don't have a clue of what's going on?
Yeah, I mean, I think certainly I can't answer that question, and we all sort of have the same ideas. I mean, I think it starts for healthcare, at least in medical school education. And I think probably I'm not in education very much, but I think reimagining the curriculum during medical school, and I think a lot of medical schools are doing just that. But we need to understand contextually what's going on in order to be able to serve our patients.
Exactly. Thank you so much for that. And Luther, you should know that we're working on our medical school curriculum revamping, and we have efforts, Tiffany Green, Laura Jacques. There's just a lot going on in that particular topic here at University of Wisconsin. So final round of applause for Dr. Howard. Really, really appreciate you being here. Now it's time for some poster viewing and back at 9:20. Okay, thanks everybody. Okay, so we're going to get started for the latter portion of the program. It's just getting better and better. Dr. Howard's address was absolutely inspiring. I've heard many similar, and hers really stands out. So really appreciate her taking the time to be with us this morning. One thing I did want to mention is we are using the word women a lot. This particular symposium is a women's health symposium, but I do want to recognize, and the entire leadership of the department and faculty want to recognize that we provide care for patients who don't identify as women. And we are continuing to strive to be inclusive in our language and be recognizing this, while at the same time realizing that the designation woman has a lot of historical context, super important in the world, and we do provide women's health, but we are also want to acknowledge that not all the people who seek our care identify as women. So with that little plug, we'll keep rolling. I'm going to introduce Dr. Lisa Barolette, who is going to introduce our next speaker. Dr. Barolette needs no introduction. She is a fabulous faculty member, prior interim chair, soon to be division director of GYN oncology, and words can't describe how fabulous Dr. Barolette is. Here she is.
Well, that was wonderful. Thank you for that. I'm going to introduce people more often. So Dr. Madeline Green is a nurse scientist whose work is concerned with enhancing equity and reducing disparities in sexual and reproductive health outcomes. So completely on point for what we've been hearing already today. Her research examines the provider and systems level mechanisms that cause and perpetuate disparities in sexual and reproductive health outcomes and interventions that can disrupt these mechanisms. I feel very lucky. I've come to know Dr. Green during her time as a Birch Scholar, and I think she really embodies our goals of that program, including building relationships, performing interdisciplinary research, and always keeping a laser focus on how to make things better for those who identify as women or those who are pregnancy capable. She is a really fabulous human being. She has all the grants, all the publications. I won't bore you with that. And I think you're going to really enjoy her talk this morning. So please join me in welcoming her.
Oh, good. I can use this. Thank you, Dr. Barolette, and thanks for the reminder, Dr. Hartenbach, to use our inclusive language. And one of the projects I'll be talking to you about today is around LGBTQ health. So that will come up a little bit. Can you please tell my department chair that I have all the grants and all the publications so that so I can make tenure? Thank you so much for the invitation to speak to you all today. I love this event. I've been coming to this event since my postdoctoral research fellowship, which was in OBGYN in the Health Disparities Research Scholars Program. And I've been really lucky to be sort of shepherded into this department. As was said, I'm an assistant professor over in the School of Nursing. I'm a nurse by training and background. But my work is really concerned with the same kinds of outcomes and access to healthcare that you all are concerned with and that you work on in OBGYN. So I think that this partnership has been really crucial for my work. And I'm always kind of waving the flag of like nurse-physician collaboration and teamwork. As we've all seen, that isn't always what's happening in the clinical world. And it's also not what's always happening in the research world. So really glad to be invited to speak with you all today. I also, in addition to thanking the department for having me, I want to make sure to thank the folks who have made my work possible. That includes really, really supportive pilot funding from ICTR, the Institute for Clinical and Translational Research here at UW-Madison. If you all don't know about ICTR, please find out about it. They have incredible resources for some of the things I'm talking to you about today.
and also from the National Institute of Nursing Research from NIH. I've also been really lucky to be funded by other NIH training awards, as Dr. Barilette mentioned, including the Birch program here. Also really want to acknowledge the Wisconsin Network for Research Support, which is a nationally recognized center for expertise on engagement in research of communities and other stakeholders. They sit over at the School of Nursing, but they are available as a resource for any researcher on this campus. They are unmatched in their expertise, their experience, and they're the most lovely people to work with. So I highly, highly recommend getting connected with them. And also everything I'm going to say today, I have learned from the team at Winners. So really those folks should be here talking to you, but since I'm the PI on the projects, you know, I'm the one who gets invited. And it's really exciting that we have the other Dr. Green, Tiffany Green, will talk to you all about a community engaged project with one of her community partners. Of course, I also want to thank everyone on my research teams and also the advisory board members that have made my research able to be engaged with communities and stakeholders. The people who participate in these advisory boards are just so brave and honest and truthful about their experiences, about correcting us, about sharing what needs to be shared with our research team. And as much as I can stand here and talk to you all about this conceptually, it's the people that are willing to sit in the room with us and participate and give us their insights that actually make any of this meaningful. So I won't spend a lot of time here because it's clear that everyone in this room, I think, is bought into what we know about what's going on with reproductive health outcomes in the US. First of all, we have a maternal and infant mortality crisis. And it's not just a crisis of maternal mortality, but it's a crisis of racism, right? We know all these statistics. We've heard brilliantly framed summary of what's going on. And we also know that there are marginalized communities that continue to experience harm, mistreatment, rejection, and discrimination in our healthcare settings. So it's super important to talk about the historical influences on, you know, why certain communities are experiencing adverse health outcomes or disparities, but it's really also crucial to acknowledge that this harm is still occurring today in clinical settings. We are still perpetuating harms against some of these, many of these communities. And we also know that we're trying to do all of this work in an increasingly politicized environment where the politics of the moment are more and more about taking away rights to access care that we know is needed. So knowing all of that, why am I going to tell you today that stakeholder engagement is a critical way to address some of those extremely important problems? We know that in clinical care, patient and family engagement has massive impact on outcomes, right? When you engage your patients and their families in their care decision-making, in their follow-up, in thinking through what will work best for them, it improves their outcomes. We know we can deliver better care quality when we engage patients and families. We reduce harm that's preventable. We can also do things at the system level like lower healthcare costs. More and more, we're finding that engaging communities and stakeholders in the research process can do the same things to our research findings. So when we engage patients and communities who are impacted by the health topics or diseases or diagnoses or experiences that we study, we are going to produce better research findings. We're going to produce findings that are more easily translatable to real change. So I love to tell I teach a lot of nursing students across the street, and I love to tell them about that finding that, you know, on average, there's a 17-year gap from bench to bedside, right? It takes about 17 years for a discovery to get into our regular standard of care practice. And they're always shocked and horrified. And that's lovely to know intellectually. But my question for myself and for all of you is, what are we doing to close that gap? What are we doing to actually get all these discoveries that we've made to improve reproductive health care, as Dr. Howard so brilliantly framed up for us? What are we doing to actually get those innovations into the hands and the care of people that need them? So as this scholar on, I love academic Twitter, but as this scholar on Twitter posted earlier this year, what happens when a knowledge gap or a gap in the literature, as we're trained to look for, has been filled, but it leads to no material changes to the populations or the phenomenons that we're talking about. And I know my colleagues in core get this, right? Like, we know all of these things about outcomes that are related to restricting abortion access, but it doesn't feel always like it's making the actual change. And that's I know that's a big commitment that they have. You can apply that kind of thinking to all kinds of reproductive health outcomes, right? If it's not making material changes to the populations that are impacted, then what is the value of producing that new knowledge? And I assert that at this point, it's unethical to conduct research without thinking about that translational aspect. So I'm going to talk to you about stakeholder engagement, which I think is a critical but not complete tool to close that gap. So of course, we need all much bigger and broader efforts towards health equity, towards racial equity, and towards inclusion in all ways. And our healthcare delivery is not ever going to solve those big social issues, but we have a role to play. And stakeholder engagement is a critical piece to making our research more impactful for populations and to meet our potential to reduce disparities. So stakeholder engagement, like so many things, exists on a spectrum. This is the CBPR, community-based participatory research model, and it shows a sort of spectrum from taking people from just being study participants to full research partners with shared stake in the design of the research, in the interpretation of data, and in the dissemination and sharing of findings and that translational piece. This is another model that talks about that same spectrum from no involvement of communities or stakeholders to models where community might be consulted or informed about the research, all the way through to that CBPR approach, and also adds this idea that communities or patients who are impacted could actually be the leaders of research teams, and that we as clinicians, as trained researchers, are bringing a specific set of skills to solve the problems that a community is facing and prioritizing. So engagement can exist sort of all along this spectrum, and I'll leave it to you to judge the two examples of studies that I'm going to tell you about on where you think they land. But most simply, we can think about it in these three ways. So either you don't include participation from communities and patients and families in your research. You might have something like symbolic participation, where you are informing people, or you have an advisory board, but they don't have any actual power to change things in the study. And the danger of symbolic participation is that it can actually further erode trust in communities. When you promise people that they have a role in your research and then you don't actually empower them to have a role in your research, it can further damage all of those ways that people think of the healthcare system and academic settings as being untrustworthy for their communities. And then you have truly engaged participation, which can look a lot of different ways. So the first study that I've conducted that in which I used engagement strategies was the study of the implementation of prenatal care coordination. Raise your hand if you're familiar with care coordination or nurse-family partnership or similar kind of home visiting programs. Okay, so not everyone. So prenatal care coordination is a Medicaid fee-for-service benefit. And the aim is to reduce adverse birth outcomes through care coordination, including home visiting, support for getting to healthcare services that are needed, education around pregnancy and the postpartum period, and helping people get access to social services that they need, like housing, food security, et cetera. Home visiting, and specifically nurse home visiting, has become a kind of ubiquitous strategy for like addressing social determinants of health. And people really believe in it. And it's extremely complex to measure the impact of a program like that on something like lack of affordable housing, right? So these nurses or home visitors are not changing the fact that there is a lack of affordable housing in Madison and Dane County. They are one at a time helping people get into housing. So the goal of this study is to figure out what PNCC is actually doing for moms in Wisconsin,
and to figure out what are the key factors in the program. So is it important that it's a nurse, or is it better? Does it work better when it's a fellow community member who's delivering the program, for example? Is it better to deliver this kind of program in a public health department, or is it better to deliver this program through a community-based organization that already has some level of community trust? So this is what we're examining. And as you can see, this is what I put in my grant. And thankfully, someone generously spent some time understanding this figure and the aims of my study, because it's massively complex. There is no consistency in the way this program is delivered or understood, and the policies are not perfect, as they never are. So because of all that complexity, we really could not generate any insight into the implementation of this program without collecting the perspectives and the expertise of people who have been working in it for longer than us and who have seen it change over time and who understand its impact. So our community stakeholder advisory board for this study consists of 5 members. We have representatives from Wisconsin Medicaid who pay for this program. We have a representative from Wisconsin Department of Health Services who administer and oversee and manage this program across the state. We have folks who are leaders of other community-based organizations that are supporting these kind of integrated care models to improve maternal health outcomes. And we have a representative from a tribal community that does not offer PNCC because of the administrative and implementation burden. So we wanted that perspective of a community that wasn't able to utilize this program. The group meets quarterly throughout a 2-year grant period, and their functions as we planned them were to advise on study processes, help to interpret preliminary findings, and recommend dissemination and translation strategies. So what does our process look like to engage this group? First of all, transparency, clarity, and planning. Always really important. So we send an agenda that looks like this every time we have a meeting so that people can be prepared for what we're talking about. We try really, really hard not to send any documents that need to be reviewed beforehand because we're already asking for a lot. We do pay members of the stakeholder advisory committee, but the payment, frankly, that we're allowed to offer is not enough to truly respect the time and the insight that we're borrowing from these people. So we really try to keep their work to the time that they've set aside for the meeting. And it's just super important to be transparent with what you're asking for from people. This is an example of a slide that we show at the beginning of every meeting. So this is our close the loop slide. So whatever was discussed in the previous meeting, we summarize here by showing the topic that we want to highlight, the feedback that we heard from the advisory board, and then the impact that that feedback has had on the study, the actual changes we've made based on the feedback that they offered us. And so this is an opportunity both for the advisory board to tell us, no, you misheard that. That's not what we said, or that's not what I said, or actually you missed a big piece in that board feedback column. And then they can evaluate whether we're really adequately making change in the study based on their feedback. So as a simple example, we had reviewed our focus group interview guide with them. They told us the ways that our questions were going to alienate people and signal to them that we didn't really care about racial equity, and how we might ask those questions in a way that signaled that we really wanted to hear about that and we understand the complexity of trying to make an impact in that area. So you can see immediately the data we then collected from those focus groups were massively changed by the insight that we gained from the advisory board telling us how to improve the way we ask questions to people and signal to them in verbal and nonverbal ways. So super important. And then we offer an opportunity to give anonymous feedback at the end of every meeting. You know, as you get to know people, maybe it's easier for some people and harder for other people to give difficult feedback about like, this isn't working, or you're really not listening to us in this way. And so we always give people an opportunity to give anonymous feedback. Now, I will say I've done this a lot of times and I never get negative comments, but you know, offering people as many formats and opportunities to give you feedback and information about your process is really important. So what have we gotten out of this? This study is very much still underway, but we, as I said, refined and improved our qualitative interview guides. We have redirected the target outcomes we're measuring in our quantitative data. So we're actually looking at different health outcomes than we proposed in our original grant. And we have begun to strategize about immediate opportunities for dissemination. So for example, next week I have a meeting with the Medicaid office to tell them what we're finding because they are currently rewriting this benefit. So they're going to use our findings in their right now rewriting of the benefit. We would never have had that connection without engaging this board. This is a poster that I just presented, and I wanted to highlight this little section of the poster that I was able to include, which is insights that we've taken from the Community Stakeholder Advisory Board. The second one here, I want to highlight. This board has been really clear that we need to be clear that this program will never resolve the centuries of discrimination that have caused racial disparities in healthcare. And if we say at the end of this study that some outcome wasn't impacted, we might be undermining the other powerful effects of the program, because a program like this cannot fix racial disparities on its own. And we're asking now home visitors and nurses to fix a problem that, like, by doing home visiting and helping people get access to services that exist. And that will obscure the strengths and the benefits of the program and potentially compromise the funding that goes towards these kind of programs. So really helping us zoom in and out at the appropriate places and thinking really critically about how we frame our reporting of the outcomes. And that kind of insight, it's just, it's invaluable. Have I already gone over my time? Okay. I always plan too much to say. So this is another study in which we engaged stakeholders through 2 advisory boards this time. And this was the readiness assessment of Dane County health systems for LGBTQ health, otherwise known as Radical Health pilot study, which I just love saying that I have a study called Radical Health. And this is our study team. So on those spectra of stakeholder and community engagement, we talked about the opportunity for research to be initiated by community members. And this is an example of that. So I have done work in LGBTQ health equity, especially around sexual and reproductive health outcomes. But this was a project that Molly Herman and Rachel Goldberg came to me and said, we just need an academic to tell someone that this is science, make it science and measurable, because we know we need to do this. And I said, great, I'm about it. So we made it science. We determined that they had a super valid measure model guiding an intervention, just needed to be adapted for this specific context. And so that's what we did. So we use the community readiness model, and this model assesses the readiness of a group to take action on a specific issue. So in this case, we're assessing a health system's readiness to improve their care for LGBTQ+ people. So instead of saying, like, put a rainbow up in June and make people feel welcome, this model takes you through a detailed assessment of what's currently going on in the health system on the ground in an everyday way. Then trained scorers in the model score all of the interviews that are conducted with staff to uncover that information and generate scores of readiness. Those scores of readiness are then connected to very specific and tailored recommendations for action that come next. So it is not generic, it's extremely individualized and tailored. And then the idea is to go back, give them some time to implement, go back and measure their readiness again and see if we've moved them along. So for this study, we had a patient advisory group, right? Because what we're trying to assess is what is really happening for LGBTQ patients in that clinical setting. So we need patients to tell us that, right? As much as we need the staff to tell us that. And we also had, in this blue triangle, we had a professional advocate team. And this is a group of people who are engaged in some professional capacity for LGBTQ equity in the area where the health system is. So in our case, in Dane County. So these are people who understand how to take information and make systems change out of it. right? How to do systems level interventions for equity and inclusion. I'm going to talk mostly about our patient advisory group. So what did this look like? This is the table that we submitted in our grant. This is a humbling process to plan a long-term engagement strategy for a group of stakeholders, and in our case, 2 groups of stakeholders. And you can see where we had time to have input and help from the winners team, which was super critical. So this is the kind of level of planning that is required. Every single thing on this plan changed. The first meeting, I think, went like that. Everything else changed. So as much as you're doing the initial planning, you also have to like flexibility and humility about slowing down, speeding up. Those kinds of things are critical. The ways that we elicited perspectives and insights from the patients in this group mostly consisted of some activities that generated their thinking and talking to us. So I don't know if folks have seen this iceberg theory. This is like visible forms of marginalization or vulnerability might be at the top tip of the iceberg. And we ask people to talk to us about what things are your providers and your health system not seeing about you that impact what it's like to get healthcare there. And this was just, I mean, I could have had 4 meetings just with this activity. Like the patients are brilliant about what is impacting their care. And when you ask them in a truly open-ended way with enough time, they will tell you what they need. I'll skip that one for time. So what did we get out of the patient advisory group in this study? First of all, they defined the problem. They helped us understand like what is actually missing, what does LGBTQ inclusion look like in a healthcare setting, and what's the difference between that and what's happening now. They selected the staff members that we interviewed, so they identified the groups of staff that we needed to talk to. They triangulated our findings from the model with their own experiences. So they had the power to tell us that's wrong. That is not what we're experiencing. That measure didn't work. And we then went back and interviewed more people and triangulated again. They also helped us prioritize dissemination strategies. So this is a book that we made, a toolkit that we made for the health system. It has a little bit of an intro about what we did and the overall findings for the health system. And then it has a tearaway page for each of the 6 groups of staff. So if you're a member of the reception team at this clinic, all you really need is this 1 pager about what we found in reception. And on the back of this page is all the recommended action steps for reception team members to start taking. Okay. I'm going to take 60 more seconds. The most important part of this is that we were able to illustrate our findings with patient quotes. So this patient said, my primary care provider, who I found after a lot of searching, is great and knows me and my identity as well, but I'm consistently misgendered at reception when I first walk in the door. So 1 member of the care team is not enough to make this kind of change, and which will ultimately impact health outcomes for this group of folks. This is the kind of feedback that patients were able to illustrate for us. So this is not us telling the health system. This is their own patients telling the health system. It's really great if everyone at the clinic is kind and welcoming and all that, but it doesn't mean much if insurance doesn't cover the thing I need. So this is the way we pointed this health system to say, you have a role in advocacy for broader policies that make it possible for people to have good health outcomes. So my encouragement to you all is to think about who the stakeholders are in the work that you do, how you can be connected with them, and ask them to be part of your project so that you're not doing them in isolation. Think about how engagement strategies might help you close the gap between like knowing that disparities are a thing and we want them to go away and actually taking action that will make change. And what will it take to have the humility to listen to patients and communities and stakeholders who don't use the same language we do, who don't speak in scientific words? Thank you.
That was fabulous. Do we have time for 1 question? Anyone in the room? I can also look online. Dr. Green, I would ask one question of you. What are some techniques that you have found to be successful in finding stakeholders? Because it seems like it would be easy to think you're doing a good job of casting a very wide net and then perhaps not do so.
This is such a good question, and I don't think there's a simple answer. I would say the strategy that has helped me engage and recruit and have on my team stakeholders that really are the right ones is time. And that's really not something that's supported by most of our job descriptions and demands of sort of our productivity, but being in the community that you care about and spending time with folks is the most important way to identify who the right people are, and then to actually be trustworthy to them. Like truly, it's things like showing up at community meetings, showing up at events, getting to know people, offering help with the things that you have to help with. So time.
Did you have a question, Dr. Hoppy?
Okay. Thank you.
Okay, so thank you, Maddie. I just wanted to personally say I've gotten the opportunity to work with Maddie in different ways and grants, and she's amazing. So reach out to her, like this physician, nurse, like even collaborative, pulling community members together, etc. Like she's a great team member and she's committed and she puts in the work, and I just can't say enough. So thank you. To switch over, we have two great co-presenters for this next talk, and it's a privilege to announce them. So, sorry, I have my cheat sheet. It is an example of a researcher and community joint presentation, and the title is Evaluating the Impacts of Wisconsin's Birth Cost Recovery Policy, a Community-Centered Approach. Tiffany Green is a nationally recognized economist, pop health scientist, and science communicator whose mission is to reduce and eliminate racial and ethnic disparities in reproductive health. She's an associate professor in pop health sciences and OBGYN here at UW-Madison. And we're really lucky to have her as part of our department and to have the opportunity to work and learn from her as well. Annette Miller has lived in Madison since 1989, so member of our community. She is the CEO and founder of Equity by Design. She's passionate about engaging the community in equity-centered efforts, disrupting and changing inequitable policies, systems and structures, as well as consulting and modeling to provide concrete action steps and increase impact and facilitate change. Really excited about this talk today, and enjoy.
Oh, this is like ahead. But my PhD is on technology. Thank you so much for having us today. This is an honor to be back on this floor. I was here 4 years ago with a new baby, explaining what I was doing here after being hired, having the honor of being hired the first to hire in the racial equity cluster hire, reproductive equity cluster hire. I'm super glad to be here. This project is many hands make light work. And I want to just thank our partners first for funding this work. Of course, the Wisconsin Partnership Program that believed in this work, County Health Rankings and Roadmaps, and the UW Centennial Scholars Program that have also funded this work. All opinions are our own and not those of our funders, so just hang on for the ride. This is a massive project trying to understand the impacts of Wisconsin's birth cost recovery program on outcomes. I'll explain a little bit more about what that is in our presentation, but first, here are academic collaborators, Dr. Laura Swan, my former postdoc and now research scientist here in the audience, my former postdoc, Dr. Hua Vu, Gina Green-Harris, David Pate, and of course, Dr. Jasmine Zapata, so Dr. David Pate as well. Annette is going to introduce our community partners.
So good morning, everybody. So obviously in doing something like this, especially given the previous presentation, really what we're doing is going to model for you like what, community and research partnership looks like. So these are our community partners, and really they're the ones who are bringing that deep expertise into the space for us. So it helps us better understand how can we reach and understand the research that we're trying to do. So Tara Wilhelmi, who's the CEO and founder of it's EDO, but Each One Teach One, which is very culturally rooted. Dr. Patricia McManus, who's the president and CEO of the Black Health Coalition of Wisconsin. Carla Peterson Gaines, Badger Care Outreach Coordinator, Jacqueline Sills-Ware, Sharon Rice, Brandis Hatcher, Deborah Nevels, and Felicia Turner Walton, CEO of Healing Our Hearts Foundation, and then myself with Equity by Design.
So this is not, we like to think about the lone scientist doing this work. That's not what we have here. It's definitely a collaborative piece of work. But birth cost recovery, why do we care about this and what is it? And it's astounding to me, I think, because this affects so many of our patients, but many clinicians and other healthcare providers have no idea what this is. But let's start with the why. As many of you know, and probably have heard today, Wisconsin has among the highest Black infant mortality rates in the United States. As of 2020, we had the second highest Black infant mortality rates in the country. And of course, we have to think not just about the babies, but about birthing people. We also have very high rates of pregnancy-related morbidity among Black birthing people. Native American or Indigenous Wisconsinites have the highest, but Black birthing people have the second highest. So what's causing all of this? We like to think about clinical drivers, but I think the bigger issue is the social environment that we live in. And when I came, someone sent me an email and said, well, what do you plan to do? And I was like, I don't know. I just had a baby and just got here, right? And I had the wonderful opportunity at Black Women's Wellness Day, which many of you did anybody attend last week. It was an amazing event. But I had the opportunity to meet Rachel Azenleko, who was he's a nurse and was a former MPH student here who did her thesis on trying to understand the drivers of high rates of Black infant mortality in Dane County and Wisconsin. And she tells me about this policy called birth cost recovery. And I'm like, well, what's that? And I had the same reaction that everybody hears when they hear about birth cost recovery. That is, it's a program where the state of Wisconsin interprets federal Medicaid law in such a way that they can make the unmarried father of the child liable for part of the Medicaid birthing cost. And everybody has the same reaction that I'm seeing in the audience, like, what? This is a thing. Wisconsin collects millions of dollars a year in these birth cost recovery funds. And so this is the start of the project. And so what I want you to understand is that this isn't coming necessarily just from my head, it's coming from people talking to me about this. And I think that's an important factor if you're going to do any kind of community engaged research, doing stuff that comes up in conversation. This also came up in another effort that Annette will discuss right here, and that is the Saving Our Babies engagement report.
So when Dr. Green talks about things coming up in conversation, myself and my co-partner, Lisa Payton Care with the Foundation for Black Women's Wellness, we were asked by the Dane County Health Council to come in and what was supposed to be in 2018, an engagement in the Black community around Black infant mortality. So, we came in thinking, hey, we're gonna talk to the community, and it actually turned out to be something so much more expansive, so much, so impactful. We ended up talking to over 350 Black women and birthing persons and their families, and collected a lot of rich data, and was able to, identify 10, key themes. But part of talking about those themes led us to talking about systemic barriers, and birth cost recovery came up as one of those areas where there was concern. And basically what we were learning is that birth cost recovery policy is a policy that further magnifies financial instability for non-custodial fathers, and it or penalizes mothers with healthcare coverage loss if they refuse to provide fathers' names. So such policies deepen many men's struggles to financially support their children and create strained family dynamics. And so what we were trying to do too, is if you look at the 10 areas of concern that these, you know, African Americans expressed, you know, they were talking about racism, discrimination, institutional bias. They're talking about bias and cultural disconnect. They're talking about inadequate social supports. They're talking about disconnected in terms of how to navigate community resources. And then the other one was chronic stress. So I'm just naming like 5 out of the 10, but this right here, this birth cost recovery, basically exacerbated every single theme that came up. And so that's what I think is really important to understand, is that when people talk about chronic stress, it's not like stress. It's like, you know, here's this program that somebody thinks is supposed to help, but it's helping who and how. And actually what we're finding out is it's not. It's adding and exacerbating. So.
Thank you, Annette. And as we said before, birth cost recovery is defined as a practice that allows states to pursue the recovery of Medicaid, or in our case, Badger Care birthing costs from non-custodial fathers. How does this work? Because a lot of clinicians that I talk to are like, what is that? Right? So this process goes the following way. So someone discovers that they're pregnant, they go to receive care. They decide whether or not to enroll in Badger Care. And so people that are already Badger Care eligible can elect to continue their coverage. A person gives birth with Badger Care, and of course the state cannot withhold care. You can't tell somebody, if you don't tell me the name of the father of your child, we're not going to cover birthing costs. That's illegal. What is legal is going after the father of the child. So the birthing parent is referred to child support, and the state asks them to request support, or the state files on their behalf.
Can I interrupt for a second?
You can interrupt.
So here's why I want to interrupt. It's because I too had children. I had 3, and my son is 30. But the experience that I had, I came in with my first child being single. And when I came in, I was actually harassed about who was the father of my child. I have health insurance. I was working, and I'm like, why are you in my business? So the reason I'm bringing this up is that I would be considered middle, you know, moderate middle class. I have a job, I have health insurance, but I am a person of color. I am African American. Okay. So that's the experience that I have. So imagine what the experience might be for somebody who's on Medicaid and Badger Care, like what their experiences are. I was able to use my voice to push back, but it looks a lot different when you are more marginalized. So this is something that is not just, it may be targeted towards people who are low income, but unfortunately, anyone who looks like me or her, or they, we all get targeted. So we all get lumped in.
Absolutely. And as I was saying before, after this process, the child support judgment is entered against the father, and birth cost recovery is part of that. And the important part that we need to realize here is that money goes toward the county or the state. It does not go for the benefit of the child. Let's say that you are a birthing parent that does not want to reveal the father of your child. There could be a lot of reasons, such as assault, domestic violence, or not wanting to disrupt a relationship. If you're otherwise eligible for Badger Care outside of pregnancy, the state can remove you from the rolls for not revealing the father of your child. And why is this structural racism? Well, it's structural racism because of the way that our society is structured. Black birthing people are much more likely to be on Medicaid, much less likely to have jobs that cover them with private insurance. And because of that, birth cost recovery by its inherent structure is disproportionately likely to affect Black birthing people and families. And the way we define structural racism here is the GN4 definition. That's my favorite. I know we have a lot of debate on what the right definition of structural racism is, but we define it as a macro level systems, social forces, institutions, and ideologies and processes that reinforce racial and ethnic inequalities in outcomes. But I'm putting on my economist hat here. And one of the things that is challenging for us is, well, is this causal, right? There are a lot of things that are associated with poor birth outcomes. Some people have argued that birth cost recovery is driving adverse prenatal care outcomes, not going to prenatal care on time, other adverse birth outcomes. But the challenge is that the same things that are associated with birth cost recovery, like poverty and other factors, are also associated with these health outcomes. So making the argument that birth cost recovery is a driver is challenging from a scientific perspective. And then I think another big perspective is Black people's voices not being centered.
Exactly. So just again, I think the previous presentation just really hyper focuses on this as well, which is we really need to center the people that we are trying to help and research and understand. So if we know that it disproportionately affects Black people, but they're not able to be in the room to talk about the ways in which it's impacting them, and not as someone who's not just only who's receiving the service, but people who look like us, who are actually sitting on the other side of the table, who can actually inform. So the beginning, middle, and end is very important in terms of representation. So thought leaders as well as people in the community. So we really worked hard to really, try to debunk this.
And I think this is not just representative of birth cost recovery, but it's very much representative of the entire clinical enterprise and social science enterprise, where researchers and scholars will talk about Black people, but not involve Black people in the research process and allow them to speak for themselves.
Right. Which okay, so I'm really
keep going.
No, I was gonna say, so I do engagement. I do center the voices of the people who are underserved and have been historically marginalized. So my biggest beef too is that, yes, you can go get the information, but also if you don't know what it means to have the lived experience, how can you hold their voice throughout the process? So that's also, so you go at the beginning and you go grab the voice and you grab the issues, and that's really good. But you know what happens in the middle is who advocates for keeping that voice centered in the process? Because all of a sudden the systems start going, well, let's really talk about, well, do you think that really was what happened? Or, well, maybe what really is happening is this. And it's like, well, now you just undid all the work from the beginning. So I think another thing that's really important is that you've got to have representation in the middle. So you've got to have people sitting at the table who have cultural relevant understanding of these issues, so they can hold those voices that you obtained, at the beginning of this research as well as the end.
So I have nothing to add. Okay. So how do we figure this out? From putting back on my economist hat, how do we think about this? Well, around the end of 2019, Joe Parisi announced that Dane County would be suspending new birth cost recovery collections. And me, the economist, was like, oh, that's a natural experiment, not knowing what would happen in March of 2020, but here we are. And so because Dane County suspended new birth cost recovery collections, I said, okay, we have this policy change that's independent of people's individual characteristics. Remember I said sort of their characteristics that are associated with poor outcomes and being on birth cost recovery. So this provides us with a kind of natural experiment to assess what the causal impacts of birth cost recovery might be on outcomes. But again, we didn't know March of 2020 was coming. So that's another challenge for another time. What are the aims of our project to understand how birth cost recovery was linked to outcomes? First, we wanted to document the lived experiences of people with birth cost recovery. And this is important from not just a justice perspective, but from a scientific perspective. When you're thinking about asking people questions or assessing the outcomes of policies, you have to make sure that the questions that you think you are asking are the questions that people think that they are answering. And to do that, we also wanted to create a survey capturing outcomes. A lot of times researchers use our science to follow the data rather than the other way around. We use the data that we have. So we wanted to create a survey that actually captured what the key metrics of birth cost recovery outcomes would look like. For example, in administrative data, we might see prenatal care, right? That's important, but I think given that in the Saving Our Babies report, we saw that this was likely affecting people's mental health outcomes, we needed to have a survey that would also capture people's mental health outcomes. And to do that, we are collaborating with the Survey Center here at UW to implement a scientifically validated survey. Now, survey methods, people will say, well, what does validated mean? Meaning that we are using a process called cognitive interviewing to make sure that the questions that we think we are asking people are the questions that they believe that they are answering. And that is a very important way to make sure that you are capturing what you think you're capturing in data. So when you say I'm using a validated measure, the question you need to be asking is, for what population? So what is our process? And now we'll talk a little bit about the process that we use to engage in this process.
Yeah, so just a little bit about equity by design and what we do. There's two areas that we really focus on. One part is public involvement, public engagement. So that beautiful like continuum of no engagement to like, you know, community-centered engagement. That's what we're about. We really work with projects, developers. We're very interested in policy. We want to really make change that's going to impact people, because that was something else that was brought up. As someone of lived experience who was in state government and local government, I was tired of, I wanted to see like how we can change and really see our voices and impacts, because as we know, policy lasts forever, right? It's really hard to change policy. So I really wanted to work at getting people's voices into the mix, especially BIPOC centered voices. And the other thing that we do is we work with organizations who are really trying to change their culture around equity and inclusion. So we do that work as well. So when Tiffany Dr. Green,
that's what you called me.
No, I'm trying to respect you. You earned your doctor. Dr. Green brought us in because of our other work. And so what we've really been doing is being a bridge between the research work and then also with the community. In this case, a community advisory board was brought together, and that is representative of those community partners that we shared earlier. So one of it is who's at the beginning, right, working with us to help inform the process. The second piece is then like, how are we reaching and engaging the community, and is what we're using for strategies the right strategy? So we're always really trying to check that. So it's us as the researchers and the person who's been brought in to do the engagement, but then also talking to the community advisory board about like, how are we doing? And is this working? And then also really trying to, in real time, activate any lessons learned along the way. And believe me, as you might imagine, in any research project, there's always something that pops up and you're like, oh, didn't expect that. So constantly being iterative in the process to make sure that we can quickly turn it around. So engage, reach, and really trying to apply the lessons right in the middle of the research.
Absolutely. And here's one example of that. Thank you, Dr. Swan, for this particular flyer. So this seems like a very simple flyer, and that's why you know how much work went into it. Part of the process of going through our community advisory board to say, does this make sense? Are people going to understand what we are talking about? And this has gone through multiple iterations, as you'll find out in one moment. This is one example of what we would work on with our community advisory board. You can see that the wording of the second question went from, has Medicaid Badger Care ever paid for all or part of the birth of any of your children? Which made sense to us as researchers, but our board was like, nah, no, that's not gonna work. Right? Like, and so we changed it to, when you gave birth, did you have Medicaid Badger Care to cover the cost of the birth? This seems small, but it's not, right? This is a really important part of our process, because one of the challenges that we have had, and I think it's very important to talk about the challenges that we have during research, is understanding. You know, the first big challenge that we've had is attempts at duplicate interviews. And I want to say this is a product of a system that leaves people impoverished, right? So there are people that said, oh, well, you're providing funds for this interview, let me take it multiple times. And thankfully, one of our RAs, who was a med student here at UW, she caught it. And we were able to address this. This is a very common problem in qualitative interviewing, especially online. A second big issue that a lot of us face is lower than expected recruitment numbers. We thought we were going to have it together. We were going to be done in a couple of months. And that hasn't happened. I think we've had about 3 or 4 interviews so far, valid interviews thus far. And the third big challenge that we've had is there is no singular way of understanding birth cost recovery. I have talked to people from so many different socioeconomic statuses, et cetera, that have experienced birth cost recovery. And they're like, oh no, I don't know what you're talking about. And then they say, oh yeah, I know what you're talking about. The father of my child had to pay back Medicaid birthing costs. The problem is that everybody sees this differently, and we have constantly had to think about how we're presenting this to make sure that we're capturing what we're capturing. How have we addressed this? One, to address the fraudulent interviews, we've implemented new screening protocols, and we also have some ways that I would prefer not to talk about here, but we can know if someone is trying to do duplicate interviews. The second thing that we do is we've been partnering with family medicine, who sees a higher proportion of Badger Care patients, to recruit from clinics. And we're also recruiting fathers, because you know who will definitely know what birth cost recovery is? The people that have to pay for it, the people that are liable for that. And we had always intended to capture fathers, but because the size of the grant, the Wisconsin Partnership Program grant, which we're very grateful for, was a little bit smaller, we had chosen to focus on birthing parents. But we quickly realized that we had to find funds from somewhere to be able to talk to fathers. And we are working on that. If you're interested in interviewing, please let us know, or you know a great interviewer, we would love to have one. And the other piece is we're working iteratively with the CAB, other partners. If I talk to you, I'm probably asking you questions to try to refine how we present birth cost recovery, because again, this is why we're going to do cognitive interviewing, because what you think people are answering is not what they think you are asking. And that is something we found over and over again. And I will say, as a quantitative person, this is very uncomfortable for me. First of all, I never wanted to do community engagement. I remember as a postdoc, Dr. Sardo made us all take a community-based participatory research class. And I'm like, I'm an economist. I don't do this, right? And over time, it is just really astounding to me how integral that early training has been to the work that I'm doing. And the thing about this community engaged work is that I've had to be uncomfortable. I have had to get used to the idea that you can change protocols midstream. I was like, is this a thing? You know,
It became one.
and it became a thing.
It became a thing.
And to be okay with things not occurring in the timeline that you expect or want that timeline to be in. So if any of my funders are here, sorry, we'll be asking for an extension. But that is so important for those of you who are doing this work. You should not be doing this work to advance your career, because it's gonna be a long payoff. And maybe it won't pay off, and maybe it will. But what we have discovered is that the questions that are worth asking are really hard. They're really hard. But I think that centering Black people in this work and being able to live out our values and to live out scientific rigor is worth it. And we would be happy to answer any questions that you might have. Who came up with those? I love that.
Right.
They're kind of cute, aren't they?
I love it. I love it.
I got you, Doctor.
Thank you so much. That was great. I think the community voice offers so much in the work we can do as academicians. And I think always including our community members in the work we do too, and the results and kind of the accolades of it, I think is really important. Something that I've learned, and it also think is really rewarding. I had one quick comment. I met the dad's doula head, and I just was wondering.
Is that Joshua?
Yeah. I wonder if you could get fathers' voices out of that, if you thought about it. If not, just thought I'd mention it.
I met Joshua was amazing. I have to in my non-spare time, I've been trying to like run around the clinics and talk to clinic directors, but that is definitely something that we plan to do outreach to Black dads and through doula organizations and some of the other organizations here in Dane County. I should say that, and I didn't clarify as well as I should have, that we're trying to reach out to folks in Madison and Milwaukee, but also for the qualitative portion of the survey, Black families across the state.
And I just want to say, because she does not have spare time, if you are able to like say, hey, I heard this presentation, you really should connect. I think that would be super helpful. I think that's part of this is, it seems like we're supposed to interview 25 people and it'd be like, oh, no brainer, we're going to make that happen. This has been really challenging. And actually another example of that iterative process is the fact that we are looking at the fathers that came out of this process. And we're hoping that that will make streamline this a little bit more, but it takes a minute to get to who's holding that richness that we're looking for.
Absolutely.
Thank you so much for sharing this. And I think when it comes to health policy, it's so interesting because at least for us as physicians, nobody really teaches us how to be advocates for health. Well, I would be happy, you know, a lot of it I think is learned sort of on the fly. And there's so many barriers for us participating in like political advocacy work. But I'm interested specifically in this, in that, is this like a law? Is this a Medicaid policy that is outside of the legislature? Like, how is this actually sort of formulated and the
Sure, those are great questions, and and this is why I try to teach and integrate health policy into anything I'm teaching to my med students, because it's really, really important. This particular policy again is the way that this state and a couple of others, but Wisconsin's definitely the biggest offender, interprets the law in a way that says we can collect these funds from fathers. Counties have a lot of wide latitude as to whether they collect these funds. Dane County is different in that one, you know, Dane County is progressive, but Dane County also has more funds. And so these funds are used to fund child support offices. And you can see very explicitly, and this is not some conspiracy I'm making up, you can see very explicitly in some of the documentation when counties are going back and forth about whether to implement this policy, that they are saying, hey, we need this revenue. We need this revenue. The Walker administration actually was pretty instrumental in making this policy less draconian. During Scott Walker's administration, he said, okay, if the parents are together, if they're living together, if they're intact, you should not be going after these families for birth cost recovery funds. And there are a lot of counties that were unhappy about that. And there have been some efforts in the state legislature. They're busy with other shenanigans right now, but to roll back this intact family policy, to make the law more strict again. Again, counties have very wide latitude to pursue this policy. There are ways that people can be exempted, but you know, poverty and legal advocacy are often diametrically opposed. ABC for Health is a public interest law firm that has done a lot of work to try to advocate for folks in this space. Hopefully that answers your question.
Thank you.
I think too, one thing I will add is that there's the policy and then there's how it's communicated on the ground to the individuals. We're finding that they really don't know there's so much paperwork that comes into the process when you come into the hospitals to get care, that a lot of times they don't even know what they're signing. And even the staff don't even know. They just are like throwing paperwork, just like, I don't know, this needs to be signed. So the way in which people are characterizing the documentation, a lot of times people don't know what it is they're signing, or they're told it's the perspective of the staff person, how they have interpreted what it is that you're signing. So it's very, very murky, which is what's making this very challenging to find people, you know, to be a part of the study, because it's clear as mud in terms of what birth cost recovery means.
I think it'd be more fun to toss it.
Yeah, right? Yeah, right?
I feel like it should be tossed, like have a little razzle dazzle.
Right?
I first learned about what I actually didn't know this was the name of it, birth cost recovery. So I've learned a lot through listening to you. So I'm really happy to be here today to listen. But I When I worked out of hospital, I had to, go to the state office and get birth certificate forms so that I could have my patients fill them out and sign them and turn them in. And they give you just so many and certain numbers, serial numbers and things. And then when I asked, on our Wisconsin birth certificate forms, of course, it says for the spot where very often the father of the baby would be, or I would consider it to be, it says husband. And I remember going down to the state office and asking the then couple of women that worked there for years, what is with this? I need to answer my patients' questions about this. Can you explain it to me? And they kind of explained, just like what you were saying, like their perspective of what it meant to be on that form. And so I've kind of, for the last, 15 years, been sort of using that understanding in my explanation, even to patients today in prenatal care, where I'm saying, if you're not married, there'll be a separate form. The only way to get your name on the birth certificate is to fill out this form. And then they put your two forms together at the downtown state office. And I do tell people that once your name is on that form, there is a chance that you are also going to be someone is going to approach you for collecting funds to support the baby, and that the state assumes that if you're married, your baby is automatically financially supported, is one of the most ridiculous parts of our processes here in this state. But I'm just wondering, what parts of those explanations that I'm telling my patients are so wrong now? I'm really rethinking things right now. And I kind of feel like I don't actually want to be the person explaining this at all. But I know it's often like the hook in postpartum, or the nurses handing the forms to patients in the hospital.
So I don't want to turn it back on you, but I guess one question I would have, since you're here, is what will be helpful to you coming from this work? How can we be helpful to the work that you're doing with your patients?
Well, now I work with UW and I catch babies at Meriter. And so I don't get my own birth certificate forms or anything, but they're the same forms so that I see in the hospital. And maybe even just having a representative from I'm sorry, the name of your organization, Equity by Design, like someone coming and just explaining to our group, maybe, because I'm sure I'm not the only one who's explaining these things to our patients, or to the HUCs, or to whoever's handing these forms to people, so that they can have a better understanding of what they're signing. I don't know.
No, that's really helpful. I know you had kind of had a question, but that's very helpful to me in terms of understanding how stakeholders could use this, because we want people to be able to use this in a way that's empowering and be able to support the patients that they serve, for communities to be able to advocate for themselves. So that's actually very helpful to us in terms of thinking about how we will disseminate. Well, it's quiet. I guess we answered everything. We did. Okay.
Thank you.
Thank you so much.
Hey, as we wrap up here, I just wanted to share a couple of things. I'm really grateful to all of the speakers and participants this morning. I know I've personally learned a lot and feel super inspired by everyone's work and knowledge that they shared this morning. A couple of little tidbits that I just want to try to share, especially with our learners this morning, is that many of the projects and endeavors that we've done in our department to try to foster health equity have started with students and residents. And one that just kept getting pinged up with Dr. Howard's talk was the aspirin recommendations. And that project that we did in our department came from Dr. Kathleen Ireland, one of our former residents. And then Dr. Maya Gross. So Dr. Ireland gave a great talk on cardiovascular health for pregnant patients and where some of our disparities were falling. And then Dr. Maya Gross picked that up, one of our other former residents, and said, hey, we can improve how we prescribe our aspirin. And we did a QI project that involved one of our great medical students who's now a resident as well in another institution. And we were able to move our aspirin prescription correct recommendation rates from like 30% to about 85% with a QI project. And so I think the things that Dr. Howard and many of the speakers are mentioning this morning are just incredibly relevant. If we chip away at each little thing, then we can all make a big difference in our community and in our patients. So I just wanted to share that little tidbit because it was burning in my brain. So first, a big thank you to our poster judges. There's a lot of work that went on behind the scenes this morning. Dr. Amy Godecker, Amy Williamson, and Heidi Jansen were behind the scenes working on things this morning. So thank you. We had a fantastic planning committee that helped to put this event on. Today, you can see many of the faces here. I won't go through everyone in detail, but each person was really instrumental in putting this morning together. So a great thanks to all of these folks. And now I get the pleasure of announcing our winners from this morning. And so first, we have 2 best poster awards. And if you're here, please do come up. We have a nice framed certificate for you. If not, we will get it to you at a later date. There is also a monetary award that will be coordinated with you by folks in our department. So the first award goes to Dr. Serena Schrager. Congratulations. Okay, we have a second best poster that was in no specific order. It goes to Dr. Laura Swan. And then our brief and brilliant talk. I know this was tough for me. I couldn't really decide who I was going to vote for, but when the tallies came in, it goes to Dr. Jenna Nobles.
I think Jenna had to go teach some class.
Okay, important work. Thank you. So as you have, I'm sure, known and figured out this morning, the symposium is an annual meeting. It connects our healthcare professionals, population health experts, and community advocates dedicated to advancing health equity. We know that these are trying times from many perspectives, and we appreciate everyone coming and supporting this really important work. And we also encourage you all to think about all those tangible kind of nuggets that you learned about this morning. Maybe it will inspire you to take on some work to chip away at health inequities. And anything that you're working on, we would love to hear and see in our next symposium, which will be in October of 2024. So thank you.